we certainly do want to make sure that we continue to center our forum on the lived experiences of women and children who are impacted by substance use. So now we're going to hear the story of another individual who is sharing through the Tough as a Mother platform. And this time we're going to hear from Alicia in Grand Junction.
Hi, my name is Alicia Kroll. I am from Grand Junction, Colorado, and I am a mom in recovery. The moment I knew I needed help was probably when my mom passed away. It really was a series of unfortunate events. In October, my husband went to prison. In November, my 3-year-old son went to live with his biological father, of whom he had never met. And February is when my mom passed away, and I really just felt lost, like I had lost everything that was important to me in my life, and how could I possibly continue to live? So I gave myself 2 options. Either I kill myself or I reach out and ask for help. And so I got honest with myself and with my probation officer, and I told him I wanted to live. And I can't get clean on my own. I admitted that I had a serious addiction to meth and heroin. And instead of putting me in jail, he actually helped me. Of course, I continued to get into trouble and just couldn't stay out of it. So they ended up revoking my probation, and they reinstated it under the condition that I go to a 3-month treatment program here in Grand Junction. And that was what I wanted. So I got what I wanted. I definitely wanted to get clean. I had been living in my addiction for 2 years, and I had already lost so much. I couldn't imagine losing anything else. So I complied. I went to treatment. I got out, and I came to an Oxford house. And today I get to see my son. Whenever I can make a trip out there. He lives in California, so it's kind of far away, but I also get to talk to him and FaceTime him every day or every other day. And I'm working towards getting some more physical custody. I do get various times of the year. I am starting to get a week. And so that's awesome. It's taken a long time to get to where I'm at. I have 17 months of sobriety today, and I'm very blessed and grateful to be alive. So the biggest change in my life since starting this journey has been the fulfillment that I get out of life today. I recently got hired on with Oxford House, which is really awesome. It's within the realm of recovery, which is a huge change for me. Everything that I do, I eat, sleep, and breathe recovery. I have a lot of support. I live in a house with 6 other women, and we all support each other. We're like one big family, and that really means a lot to me because I have lost a lot of my family due to addiction. And so living in a house full of recovering addicts has definitely changed my perspective on life today. I think what I most need to say is to my loved ones, my father, mainly because he's the only person that I have left, and he's never once given up on me. He's never once stepped out of my life, and even when I was difficult, he was always there for me. So I want to say thank you, Dad. I appreciate you. I love you. As far as the community, never give up on somebody who is in active addiction or in recovery. People are changing rapidly, and all they need is healthy support and the will to get better. That's really all it takes to get into recovery. If you can reach out and ask for help, or if somebody notices the signs of somebody in active addiction, like reach out to that person. Don't let that person die, because you never know when somebody is going to die from an overdose or from suicide. Addiction takes a huge toll on a person, and all they need is somebody to tell them that it's going to be okay. My name is Alicia Kroll, and I am tough as a mother.
Thank you so much to Alicia for sharing her story. Now we'll move on to the next item on the agenda, learning about how we can send families home with naloxone, the experience of Swedish Medical Center. And so it's really my pleasure to welcome Dr. Dawn Stader, as well as Mary Gambato. Dr. Stader is a board certified emergency and addiction medicine physician, opioid expert, film producer, and social entrepreneur. He works at Swedish Medical Center in Englewood, as well as at the Lincoln Health Community Hospital in Hugo, Colorado. Mary Gambato is a perinatal nurse practitioner and navigator at Swedish Medical Center, who's the lead on her unit on the Colorado Naloxone Project and the provider champion for Swedish Medical Center and the Colorado AIM Substance Use Disorder Learning Collaborative. So thank you so much for your time and for your expertise.
Thank you so much, Susan. I really appreciate the introduction. I'm going to start off with a piece of sad news or bad news, which is that Mary just texted me and said that she's going to be unable to join. They have a sick laboring mom who might be going to the OR with her. So sadly, she will not be joining us. I'm sure that many of the clinicians on this call can relate to similar stories. So best of luck to Mary, and best of luck, of course, to the patient for whom she is caring. I'll start by just saying that this is going to be pretty informal. So please ask questions. And really, at the end of this, at the very end of our talk, the take home is going to be very simple. I want everyone to think of naloxone and to want to start a take-home naloxone program in their labor and delivery unit or in their clinic to better serve the patients that you see who have substance use disorders. I will kind of walk through a lot of the evidence behind it, what we're doing with the Colorado Naloxone Project, and then have a lot of time for Q&A where we can really get into some nitty-gritties based more on what your needs are than what I think you need to hear. So we'll start just the basics. As an emergency doc, and probably many of you as clinicians see, that we have a spiraling opioid crisis. We have fentanyl in Colorado and across the nation that is driving some of the worst overdose numbers that any nation on the face of the planet has seen at any time in history. We lost 107,622 Americans to overdose in 2021. Here in Colorado, we lost around 1,913 Coloradans in 2021. We have one overdose per every 3,000 Coloradans. And just to put that in context is if you fill up Mile High Stadium during a Broncos game, we have 75,000 plus fans who would be in the stands. We would have around 25 overdoses for that full stadium. So I cannot overemphasize how prevalent the disease of addiction has become and how prevalent opioid misuse has become. And with fentanyl, how prevalent overdoses have become. Now, we know that from both national statistics that overdose is the #1 killer of people under the age of 50 in the age of COVID, and that has significantly worsened with all the mental health anguish that people have experienced during COVID, and sometimes the poorer care that they're able to access because of an ongoing continuous pandemic. And what we also know, and what you guys all know, is the people most likely to overdose are people using drugs, and those disproportionately are people in their childbearing years. So if overdose is the #1 killer of Americans under the age of 50, if most patients that you serve are under the age of 50, it bears really common sense that overdose year after year is oftentimes the #1, #2, or #3 killer of pregnant moms. And the evidence is kind of all over the place, but in the studies that we have done in our state, we see that maternal overdose is one of the top killers of mothers, oftentimes exceeding preeclampsia or other things which we focus a lot of our attention on. So we know that the need is great. We know that this is killing moms, and each one of these deaths is preventable. It doesn't have to happen. And we have oftentimes the tools that we need to help prevent these deaths and to help save moms' lives. So let's talk about naloxone just for a little bit. Okay? So naloxone has been invented 61 years ago, has has been available to use for 51 years. And we've been sending naloxone home with community members, with lay people for 26 plus years. The Colorado Naloxone Project started with a very simple premise. We have an evidence-based intervention for preventing overdose and treating overdose. Should not 100% of the medical establishment be utilizing this intervention to help decrease the really out of control overdose numbers that we're seeing in our population and oftentimes among the patients that we serve? I think the answer should be, well, hell yes, that makes common sense. Why haven't we been doing that for the last 20 plus years? But when you look at the literature, you know how many people have done this from labor and delivery units? I think we might have the first 5 in the country as part of this Colorado Naloxone Project, or at least be leaders in the country with what we're trying to do from labor and delivery units. Naloxone is very evidence-based, by the way. So we know that when you give people naloxone, it does a few things. One is if that mother overdoses and you train the family on how to use it, that mother might be reversed and you might save both a mother's life and a child's life. Oftentimes when people get naloxone and actually overdose training, they've been shown to then go on and train 2 to 3 other people in their community or in their families. It's been shown that people who get naloxone and are given naloxone training oftentimes will start using drugs more safely. And it also has been shown to improve the chance that someone actually seeks out and enters into recovery. So all these studies that happen around naloxone usually show a significant benefit to the intervention in itself. Now, is prescribing good enough? This is the question that I often get from lots of clinicians. Well, Don, can't I just prescribe naloxone? Why do I have to give naloxone directly in someone's hands for it to be effective? And the answer is that people often do not fill the naloxone that you prescribe because of stigma. If you can imagine being a pregnant mom who struggles with drug abuse, who oftentimes comes from a background of trauma, who oftentimes struggles with anxiety or depression, 2 comorbid things we see often in our patients with substance use disorders. The last thing that they want to do is go to a pharmacy, a public place, with another professional with whom they don't have a confidential relationship with, and then ask to fill a prescription for a drug that often identifies them as someone who struggles with a substance use disorder or drug abuse, especially when they're pregnant. You can imagine that being much more significant if you lived in a rural environment where you might know the pharmacy or might run into community members who might see you filling a script for naloxone. So in the studies that we've conducted from hospitals and especially from emergency departments, we know that hospital fill rates for naloxone that's prescribed is anywhere from 30% to less than 1%. And there's 2 studies in the emergency medicine population that show that when someone has overdosed, no higher risk, and you give them a prescription for naloxone instead of giving them naloxone in hand, it's only around 2% of those patients who fill that prescription. So I don't think that prescribing naloxone is actually the intervention that we need in order to really help save people's lives and get this life-saving drug into the hands of pregnancy-affected mothers and their families. Moreover, there was one study that was published in JAMA Open in 2020 that actually looked at methadone patients. So oftentimes when someone is pregnant and they have a substance use disorder, it's this really great opportunity to get that mother into treatment and often to get that mother into recovery. We've seen nothing motivate people with the disease of addiction the way that a child or the way that being pregnant can sometimes motivate people to seek recovery. And we've seen in that JAMA Open study in 2020 showed that it was around 25% of their women who newly enrolled in a methadone clinic were pregnant. And when those women actually received naloxone to take home with them, it's around, I think, 18% of them actually used that naloxone. So that's a pretty good percentage of people who are actually using naloxone. And they did not use it on themselves, of course, but oftentimes they used it on family members, on their significant others, or on friends. So when you identify someone who has a substance use disorder and you send them home on naloxone, you actually not only keep that patient safer, but you keep the community around that patient safer. And what that means for oftentimes that infant being born is if their father also struggles with drug use or drug misuse, that often if that mom has naloxone at home and can save that father's life, then you have an intact family that that child is born into. Granted, an intact family that needs to work toward recovery so that they can be good parents to that child, hopefully. But still, we want to give as many families as possible that opportunity to remain intact as we possibly can. There's another thing. So the evidence is robust. The last thing that we have that's extremely unique that's in our state is we have our organization, of course, and the Naloxone Project is reorganizing as a 501c3. And we have regulation and laws that we have fought for over the course of the last 5 years that make naloxone very accessible to patients, that make hospital systems reimbursed for naloxone that's dispensed, and that make the regulations easier. So I'll just touch on some of those, and then I'm going to end with what Mary would have talked about, which is what does naloxone do at the bedside? So first of all, with the regulation, we have 2 bills, House Bill 1065 that passed in 2019 that stipulates that hospitals and labor and delivery units that dispense naloxone, that hand naloxone directly to patients, need to be reimbursed by payers. So that covers all our private payers in our state. In House Bill 1326, which many of you might recognize as the fentanyl bill, that has just passed through the Senate and House and will be signed by Governor Polis later, probably this summer. That bill, we've actually included 2 pieces of legislation that we were able to add. One that stipulates that Medicaid has to reimburse hospitals for naloxone that's given out. And the second piece that makes it easy for your hospital to store, to dispense, and to give naloxone without actually going through many of the labeling requirements, storage requirements, and documentation requirements that we need for other drugs that we dispense. So we'll be taught, if you are interested in doing this, I have lots of information about how this is not only easy to do, evidence-based to do, but we've actually addressed many of the concerns around payment and around compliance with medical standards when it comes to giving out naloxone. The final thing is the Naloxone Project. Now we've celebrated just recently our 1-year anniversary. If you work in a hospital, there's a great chance that your hospital is already a participant in the Colorado Naloxone Project. We have 106 Colorado hospitals that are participating in the Colorado Naloxone Project. Many of them have only implemented in the emergency department, but our ask for our year 2 and our major thrust is going to get this into every single labor and delivery unit in the state is our goal, is one of our stretch goals. And we really need everyone who's part of the Chosen Network to help us accomplish that. And we are very, very interested to help partner with any of you who might want to open a take-home naloxone project and be part of the Colorado Naloxone Project for our labor and delivery units. We currently have five hospitals that are involved with labor and delivery take-home programs. Swedish Medical Center, where we've had our first, and which Mary was going to speak to. We have Penrose St. Francis in Colorado Springs. We have the University of Colorado Health System. I think their main campus at Anschutz. We have Presbyterian St. Luke's, and we have Rose Medical Center. Some of those are still in the process of finalizing their protocols so they can start it, but we have 5 hospitals, at least in our state, that are going to be having naloxone programs from labor and delivery units as well. And I see in the comments that Valley View is also doing that, which is absolutely amazing. So finally, let's talk about what naloxone does at the bedside. And I don't work in the labor and delivery unit, so I will speak to what this has meant, at least for me, in the emergency department, and how naloxone transforms the relationship that you often have with people with labor and with substance use disorders. First of all, I'll start with my own background of saying that I did not used to get along with people who had problems with substance use. So this is a patient population that we have a lot of shared trauma in. I've been spit on, yelled at, fought with people who are using substances, whether that's methamphetamine, whether they're withdrawing from heroin, whether they're on some other substance that's altered their sensorium and their ability to think and act in an appropriate manner in the emergency department. So this is a patient population that I came to that I actually did not necessarily get along with or like very much. I recognized around 7 years ago that I actually had a huge role to play in the fact that we were not having a good therapeutic relationship when I interacted with this patient, the population, and then went along reforming my own behaviors and my own stigma and baggage that I often brought to those relationships. I will say now, fast forward 7 years, these are some of my favorite patients to interact with, because I feel like I have the tools, the language, and the understanding of how to care for them that allows me to actually foster therapeutic relationships and help patients get into recovery. So what I will say is, when you actually start talking with patients about substance use, oftentimes they're guarded and they don't want to expose to a medical provider, especially when pregnant, that they struggle with drugs. We know that people will often lie about substance use because they don't want to feel that social stigma and shame around drug use, especially when pregnant. So when you actually start, not with do you use drugs, but I often start with, does anyone around you or does anyone that you know of struggle with drugs? And if they say yes, I do have my cousin, my uncle, my significant other, I oftentimes would offer them naloxone and say, listen, we care about every single person who uses drugs, and we want them to be safe until the time that they're ready to recover. So we have a program where if you use drugs, or if you know someone who uses drugs, we send you home with naloxone so that if, God forbid, they overdose, you're able to save their life and give them a second chance of recovery. And we, if perhaps you did also struggle with drug use, we have treatment that's available, and we'd want to help you get into recovery for yourself and for your new child who you're carrying currently. And that's a much better way to get at it than asking people directly about whether they use substances or not. Is one, normalizing the treatment of substance use disorders, offering a tangible sign that you care, that the person matters to you, and that you're committed to their care, which is what naloxone does. And then offering an open door policy. If in the future they want to say, yes, I struggle with substance use. Yes, I know I need help. And I think that we know of, at least there's one other place in the country that we had a conversation with, thanks to Katie and linking us up, is there's one other place in the country that we know of that's doing this for their labor and delivery unit. It's one hospital in, I believe it's New Hampshire. And they actually give naloxone to every single pregnant mom that they encounter. And the mom has to actually turn it down in order to not take naloxone home with them. And what that does, again, is it normalizes this and it opens the door to a much more transparent, realistic, and therapeutic conversation about drug use that we know is rampant right now in young people of childbearing age, and allows us to more readily identify people who are struggling and offer them treatment so that we can not only decrease overdose deaths, but also improve the chance that they're going to have a healthier pregnancy than someone who might be hiding their substance use and continuing to use throughout their pregnancy, and then delivering a child that might be opioid dependent. So again, there's a lot we can do to help implement this within hospitals across the state. We've also, if you are thinking of implementing a take-home naloxone program, we have developed a lot of things through the Colorado Naloxone Project that we are eager to share with you. We have training videos for how to recognize overdose, use naloxone, and then the appropriate next steps that are available in both English and in Spanish. And we have a labor and delivery toolkit that we've developed over the course of the last year that's specifically meant for labor and delivery units that are implementing a take-home naloxone program. And finally, We all know that naloxone is a wonderful, wonderful first step, but that really every mother who struggles with opioid use disorder deserves treatment. And we need to close the treatment gap for those moms who do come forth and state that they have a substance use disorder and want to get into recovery. All of that recovery should, as an addiction medicine doctor, be medical assisted recovery for the most part, or recovery that at least has the opportunity of buprenorphine, methadone, or naltrexone. Of course, in the pregnant population, we're talking about methadone and buprenorphine preferentially, but to get into recovery and to have a healthy pregnancy and hopefully a healthy life after delivery. So with that, I've been talking for a good period of time now. I'll shut my mouth and try to answer any questions that you may have. And otherwise, I hope that each and every one of you will take this opportunity to take me up and to give naloxone, like I have in my hand, directly to substance use affected mothers or to substance use affected families, even if the mom is not using, because it's a common sense, evidence-based intervention that we can take on that saves lives and keeps families together.
Thank you so much. That was incredible. I feel so siloed in the work that we've been doing that I knew so little about this amazing project that you've been leading, because this is certainly an area that we have been thinking about within our chosen quick hospitals, especially as it relates to a safe discharge of the substance exposed newborn and the family from the birth hospitalization, and wondering how we integrate naloxone distribution into that safe discharge plan. So this is really wonderful. I see some questions and comments coming in, all positive comments. Feel free to chat in or unmute yourself for questions. I'll start with one that was hinted at by Lori Helmo, wondering if you or your group have experience with trying to distribute naloxone in pediatric offices or in the neonatal intensive care unit or the well baby nurseries. Oftentimes the pediatric and the newborn providers do develop really positive relationships with families, especially in recent years, as hopefully, stigma is being reduced, and wondering if in the pediatric setting, there's an opportunity to distribute naloxone. Oh, I think you're muted.
The answer is 100% yes. I know that at Swedish that we do give out naloxone through our perinatal environment and our perinatologist. That's one of the things where Mary coordinates with families, because sometimes too you have a child that's born and then you discover in that immediate perinatal period the child starts developing neonatal withdrawal syndrome, and suddenly you're like, oh wow, this is a mom who actually his pregnancy, has had a pregnancy that's affected, especially if they've not been there for prenatal care prior to that. Sometimes those are surprises to everyone involved. And I think that what that does as well is it helps if that relationship has not been therapeutic. It helps bridge that divide, that you're actually there not to judge, but to care, right? Because as the common saying goes, is people won't care how much you know until they know how much you care. And again, naloxone really helps bridge that for many people, where it's a physical manifestation that you care about them, that you're not judging them, that you want the best for them. And that type of relationship really helps bridge that person from sometimes active use to a mindset of recovery, or where they want to seek recovery. The other thing is we are actually doing this through Children's Hospital. So we have the four Colorado Children's Hospitals are part of the Colorado Naloxone Project, and giving out naloxone through their emergency departments to adolescents most often who are affected by substance use. We've all known, and you've probably seen stories which are tragic, of high schoolers or adolescents who have succumbed to fentanyl overdoses, sometimes from unknowingly using fentanyl, or sometimes to knowingly using fentanyl. We know that adolescence is a time of significant experimentation when it comes to substances and other behaviors. So really, we want to meet people where they're at. I mean, it's not a surprise that sometimes kids use drugs, that kids sometimes get pregnant as well, right? Those are all different behaviors that we see very commonly in adolescence. So 100%, there's no wrong place to give out naloxone in the health system. And we would love to develop with different partners, different resources to use in the perinatal environment, in the labor and delivery environment, et cetera. And like we said, we've identified this as our year 2 kind of large initiative, is to make sure that we build upon the success we've had with our 5 initial labor and delivery units, and really help grow that into an entire ecosystem where pregnant, where substance use affected mothers, their families have access to naloxone and better access to recovery.
We have a question here from Shannon Bryan, wondering if you have resources about the startup costs for partnering with this program for a local hospital. She's about to jump on a call where they're supposed to be suggesting ways to invest opioid recovery funds. Mm-hmm. And I think kind of thinking about directing those funds towards your sort of work.
Yeah, so like I said, we're a nonprofit. So, we have some fixed costs. We, of course, like to pay for our staff time, and we develop items that are free. We have received donations of naloxone that we've used to power the initial costs of many programs. So, for example, every one of those 5 hospitals that signed up to start, we've given them 48 boxes of naloxone to start giving them to pregnancy affected mothers. I will say that we have wonderful relationships with other grantors, be it the Office of Behavioral Health, with the Attorney General Office, who is going to be overseeing, of course, opioid settlement dollars and others. And we are hopeful that we'll be able to get more grant funding to be able to supply naloxone to hospitals that are looking to implement this program. The startup costs are very, very little. Let me say, outside of, I think if you factored in training costs for your staff and other pieces, the fact that naloxone is now reimbursed, that we fought very hard to actually accomplish by most payers, means your hospital won't be paying it out of pocket. We realize that the legislative environment and the regulatory environment are somewhat different. So there's usually a year or 2 lag time between when we actually have a system where every hospital that dispenses naloxone reliably can bill for and get reimbursement for naloxone. So in that interim period, we've actually secured lots of doses of naloxone that we can start sending to hospitals, so you can start the program and start having benefit for your patients today, while we figure out those regulatory pieces that make sure that this is sustainable, not just today, but 10 years from now, when this will hopefully require 0 grant funding and just be part of what we do, right? That's the ultimate vision that I've had, and why we fought so hard for regulation and legislation that just makes naloxone reimbursable, because I don't think this should be a grant-related program. The evidence is too strong. This should be standard of care. And that just means that we need to put it through the regular medical system. We have a service, we bill for the service, you get reimbursed for the service, and we can reliably deliver this time and time again to our mothers in the future who might be affected by substance use. Mm-hmm. Lastly, let me add something, which is I see a comment about a 12-year-old who was declared dead from fentanyl use. Those are tragic stories. I had a 16-year-old who overdosed in the last month, who again was, fentanyl is just way too prevalent right now. But the other thing that I will say is, you should be giving this to everyone who uses substances, period. Because if you're looking at an illicit drug supply, we know that fentanyl is in cocaine, fentanyl is in methamphetamine, fentanyl is in almost every illicit product that's out there. And so often what you find is people are using an illicit, not thinking it's fentanyl, but then getting into trouble because it is fentanyl. And that's illustrated by, of course, our Commerce City story, where we had 5 people who thought they were using cocaine, who were instead snorting fentanyl, had 5 deaths that occurred, including multiple people who had families that they were responsibly caring for. One was a mother of 4. So we know that our drug supply right now is extremely, extremely dangerous, is fentanyl laden. And I give naloxone to actually anyone using substances that I see in the emergency department, whether it's methamphetamine, cocaine, The only people I basically don't do is people who are drinking alcohol or who might be using marijuana that they purchase in a marijuana dispensary, just because that's all more tightly regulated. But naloxone should be much more common, and we as medical providers should be some of the main purveyors of naloxone to our patients. I may include, and I can go through and include some of this later, some of the resources that we've developed, such as the toolkit. We, of course, have our website, which has links to our toolkit, which I'll pop in the chat as well. It's naloxoneproject.com, and we have labor and delivery toolkits, etc. We also have several stories that we developed and videos that we've developed that educate. We have an interview. I'm not sure if people recognize the name of Mandy McGowan, but Mandy McGowan is a person who probably had the most famous overdose video, one of the most famous overdose videos on the internet, where she overdosed and her 3-year-old child was with her in a store. And Mandy is now in a long-term recovery, just an amazing human being. That's what you'll find about a lot of people having the pleasure of being an addiction medicine doc, is a lot of people who do get into recovery are some of the wisest, kindest, biggest hearted people you'll ever meet. So there's a lot of really tremendous people we lose because we don't offer them recovery or build those bridges to get them into recovery. But Mandy is one who of course was using during some of her pregnancies, and especially after her pregnancies. And thank God she's alive, because now she can be a much more involved mother to her kids. And again, is why your patient population and you as providers are so important as our next front in this war to confront the opioid overdose crisis.
I was wondering if the hospitals that are participating in this effort are collecting data around the number of patient contacts or number of naloxone packages that have been distributed. And my second question, I suspect I know the answer, is actual kind of use, whether or not if it's for Colorado or just elsewhere, the frequency with which, if a family has it in the home, if it's used.
Those are great questions. We are I will say, from the Colorado Naloxone Project perspective, we are collecting data on naloxone dispensing and how many kits we're giving out. In the first year that we had, we provided around 18,000 naloxone kits to hospitals across the state. Of those, I believe we're up to 5,000 of those kits have been given to substance use, to people who are using substances. So again, we have a burn rate that's pretty good, and a lot of programs have just come on board in the last few months. And in terms of how many, always in this research, the most difficult data to acquire is how often naloxone is used by people you give naloxone to. And that's because oftentimes people who struggle with use disorders are not the best about filling out surveys or communicating. Oftentimes they're unstably housed, have financial instability, don't have a cell phone, don't have an address. So that's really been the most difficult thing to acquire is the outcomes data from people who are given naloxone. What's the shelf cabinet life of naloxone? Pretty good. It's several years, and also after the expiry date, naloxone remains biologically active for, I think, 1 to 2 years after it's expired. So it's not like, another common take home we give people is epinephrine, of course, for allergic reaction. Epinephrine actually degrades pretty rapidly, and that's why people need to get EpiPen so frequently. But naloxone is actually a very stable molecule, and there's multiple studies showing stability long after the expiration date of the package. So,
any questions?
Yeah, great questions.
All right, great. Well, thank you so much, Dr. Stader. This was incredibly helpful, and I have no doubt that folks from our steering committee here at Chosen will be reaching out to really figure out ways to operationalize naloxone distribution into our neonatal and kind of perinatal care centers.
Yeah. And please, for anyone, I've seen a few different messages, but please email me if you're interested in being labor and delivery site 6, 7, 8, 9, 10, etc. We would love to partner with you and make sure that we provide resources, technical assistance to you as you stand up, hopefully even donated naloxone product to you. We really are committed to providing better care to pregnancy, substance use affected pregnant mothers, and are hopeful that you can be a really valuable partner to us in that effort. We know that right now 90+% of emergency departments give out naloxone. I would love us in 2023, around the same time, to say that 100% of labor and delivery and perinatal units provide naloxone to people they identify at risk. That's really my dream, is that becomes that ubiquitous, that common. So we need everyone on board if we really want to reach that aspirational goal. And I look forward to working with many of you to hopefully get us there.
Fantastic. Thank you so much.